action-packed agenda today, most notably with the assistance of our amazing subject matter experts. We'll be kicking off our social isolation domain, and we welcome you all to the call. We're going to go through a few items and then ensure that our subject matter experts are on the call, and then pass the mic to them, and then return to the rest of our presentation. Next slide, please. There's Ed. Hello. Thank you for joining the Gravity Project Workgroup meeting. Due to the large number of attendees, participants are always muted upon entry. We ask that you remain muted to avoid background noise as we have our conversation. The call is being recorded. Recordings are available on the Gravity Confluence page following our presentation. You're always encouraged, though, even as much as we ask folks to remain muted, I do the best I can to ensure that we're gleaning everyone's thoughts from the chat and we integrate those concepts into the conversation. When you're sending concepts and comments, please just try to send them for everyone. And just as a note, it's very difficult for me to differentiate private communication from public communication. So if you're sending it to me privately, I'm bound to read it out loud. So just know that as we go forward. Next slide, please. This is our common Gravity Project antitrust practices slide. Next slide, please. If you've not already done so, we officially invite you to join the project here. You'll notice, I think I neglected to mention this, but I'll say it now. As we mention links in our presentation, we do try to add those links to the chat for easy reference and use by our community members. So this first one is officially joining the project. And then if you want to check and see if you've already signed up or if others from your organization have signed up, you can review existing membership at the second link. And then the Confluence is a whole amazing array of information, which is at that final link right there. Next slide, please. This is just a very, very grateful nod to all of our project founders, grantors, and in-kind support. We are a many hands make labor light organization. We are only able to do what we do with the assistance of our community, lending their labor and lending their financial support to this work. So thank you very much. Next slide, please. This agenda is going to be tweaked a little bit in order to allow the subject matter experts to present their work. So usually we go through announcements and a project schedule before and then kick off into the terminology work. What we're going to do right now, and I think we have everyone on hand, is we're going to shift and do the social isolation kickoff first. This is to adapt to the fact that the social isolation SMEs are going to focus their time during the social isolation time, and then they can leave the call and go off to the other elements of their day. And then we will return. I'll kick off announcements and project schedule. We'll do the end-to-end review for material hardship. We'll do some brief identification of stress, screening, and diagnoses elements, and then we'll pass the mic on to Bob for the technology update. And thank you very much. And next slide, please. It is now my honor to kickstart the social isolation kickoff. We are joined by three very wonderful subject matter experts. I'm going to briefly give their information on the next slide. Next slide, please. So first, Eddie Garcia is the Executive Director of the Foundation for Social Connection, a nonprofit organization in the U.S. aiming to foster evidence-based solutions addressing social isolation and loneliness. He's also the Senior Advisor to the Coalition to End Social Isolation and Loneliness, a multi-stakeholder organization whose focus is to create awareness around social isolation and loneliness and to advocate for policy reform to combat this issue. Eddie's also the co-chair of the Global Initiative on Loneliness and Connection, a newly founded consortium of nations seeking to address and combat loneliness and promote social connection on a broader scale. Eddie's also a partner at Healthsperian, a nationally recognized healthcare policy consulting firm focusing on accelerating responsible and sustainable healthcare system innovation and transformation to improve health outcomes for all, particularly the most vulnerable. Eddie received his BA in Political Science and Comparative Health Politics from BU in 2004, and in 2008 received his Master's of Health Science and Public Health degree from Johns Hopkins Bloomberg School of Public Health. Our next subject matter expert is Dr. Julianne Holt-Lunstad. Dr. Holt-Lunstad is a professor of psychology and neuroscience at Brigham Young University, an adjunct professor at Swinburne University of Technology, Melbourne, Australia, and the chair of the Scientific Advisory Committee for the U.S. Coalition to End Social Isolation and Loneliness. Dr. Holt-Lunstad's research is focused on understanding the long-term health effects, biological mechanisms, and effective strategies to mitigate risk and promote protection associated with social connection. Her work has been seminal in the recognition of social isolation and loneliness as risk factors for early mortality. She serves as a scientific advisor and consults regularly for organizations across sectors aimed at addressing this issue. She's provided expert testimony in U.S. congressional hearings, expert recommendations for the U.S. Surgeon General Emotional Wellbeing in America Initiative, served as a member of the UK Cross-Departmental Loneliness Team, and as a member of the National Academy of Sciences Consensus Committee. Her work has been widely recognized within her discipline, including several awards, and is regularly highlighted in major media outlets, and this is true. We just had a few notices regarding her earlier today. And then lastly, unable to join us today, but another amazing partner, member of this team is Dr. Matt Pentel. Matt is an assistant professor at UCSF, where his research is conducted with the UCSF Center for Health and Community, the UCSF Social Intervention Research and Evaluation Network, our friends, and the UCSF Preterm Birth Initiative. His research focuses on the utility of incorporating social information into clinical decision-making, addressing social needs in clinical settings, data mining, and the analysis of large data sets and biological manifestations of the social determinants of health. So amazing to have these three. It's my honor we are going to pass the presenting over to Dr. Julianne Holt-Lunstad in order to begin our presentation and our social isolation kickoff. Thank you so much for joining.
Thank you. I think Eddie wanted to say a few quick remarks before I jump in to present.
Thanks, Julianne. Thanks, Julianne. I appreciate that. And I just wanted to say thank you to you all for one, doing the tremendous work that you have been doing on this project, and to thank you for acknowledging the need for social isolation and loneliness to be a part of the taxonomy development and incorporation into the medical system. I've asked Julianne to take the lead because she absolutely is the real expert on these issues. But I'll be working with her in the background as we progress. So thank you. I'll turn over to you, Julianne.
Thank you. I'm going to go ahead and attempt to share my screen here. Let's see if I can. Are you seeing just one slide?
We are, and it's beautiful, Dr. Holt-Lunstad.
Okay. Thank you. And thank you so much for inviting me to be a part of this and recognizing the importance of this. As mentioned, my name is Julianne Holt-Lunstad. I am a scientist who studies the health impacts of social connections, and I'm a professor of psychology and neuroscience at Brigham Young University and the chair of the Scientific Advisory Council for the Foundation for Social Connection. And I was asked to just simply provide a quick overview of the significance of this issue, the impact, and some next steps. So across multiple studies, when subjects are asked what brings them happiness, it's not money or success. It's actually satisfying relationships with family, friends, and other close relationships. It's relationships, and so it's not surprising that most of us recognize that our relationships bring us joy or influence our emotional well-being. However, when it comes to health, it's often assumed to be primarily an issue of mental health. And unfortunately, few recognize the profound effects that social connections have on our physical health as well. I had the honor and privilege of serving on the National Academy of Science committee that published a consensus report on the medical and health relevance of social isolation and loneliness in older adults. And in this report, the committee found substantial evidence that social isolation and loneliness are associated with a greater incidence of major psychological, cognitive, and physical morbidities, and lower perceived well-being or quality of life. Some of the most compelling evidence comes from the association of social isolation with a significantly increased risk for premature mortality from all causes. In my own research, we benchmarked the meta-analytic effects of various indicators of social connection or lack thereof relative to other well-known risk factors for mortality. Of course, some variables were inversed since some are protective while others are associated with risk, so that each bar represents the strength of the effect on survival. As seen in this figure, social factors that are depicted in the orange bars are comparable and in many cases exceed the risk associated with other factors depicted in blue bars, these factors that are taken quite seriously in public health. Although these vary in their magnitude, even some of the least robust of these, loneliness was found to exceed the risk associated with physical inactivity, obesity, and air pollution. Of course, these factors are given a great deal of attention and resources, and this evidence suggests that social factors, including isolation and loneliness, should be prioritized to a similar degree. This is consistent with evidence that social isolation and loneliness also influence a variety of health outcomes, including economic. So when we look at physical health outcomes, this has been linked to increased risk for heart attack and stroke, type 2 diabetes, as well as immune and respiratory illnesses. When it comes to mental and physical health, this has been linked to increased risk for depression and anxiety, suicidality, and addiction. When it comes to cognitive health, there's evidence of links to mild cognitive impairment, dementia, and Alzheimer's disease. And social isolation and loneliness even influences economic outcomes. So for instance, a AARP study found that social isolation among older adults is associated with $6.7 billion in annual Medicare spending. And the economic burden of loneliness and isolation is likely to be much larger, given that it's also been linked to greater workplace absenteeism, lower productivity, and lower quality of work. There's also further evidence related to other kinds of outcomes. So a review summarizing 35 years of studies identifying factors associated with susceptibility to cold and flu viruses. In a series of studies, results show that participants experiencing an interpersonal stress, such as loneliness, had a greater chance of developing an upper respiratory illness when exposed to cold viruses. And so this suggests that loneliness may play a similar role in response to COVID-19. Also relevant to this current issue is that those with greater social support were more likely to mount an effective immune response to a vaccine, suggesting additional important implications. However, even prior to the pandemic, we had evidence that a significant portion of the population was already socially isolated, lonely, or both. And importantly, this doesn't just occur among older adults. And in fact, there's evidence across multiple surveys suggesting that the highest prevalence is among younger adults. So when it comes to actual prevalence rates, while there are several national surveys that have documented these, according to a 2018 AARP study, 1 in 3 older adults is profoundly lonely, and other surveys suggest it's much higher. For example, Cigna's national survey reported prevalence rates of 46% in 2018 and 61% in 2019, suggesting that loneliness prevalence rates were rising even before the pandemic. Surveys also suggest that loneliness occurs across age, income levels, living situations, and gender. However, rates are highest among those at younger ages, lower incomes, and those with chronic health conditions, as well as those who are living alone. Since the pandemic, research has been trying to determine if loneliness is increasing, and if so, among which groups. There have been several cross-sectional studies, meaning that they were asked people at one point in time to what extent did they feel that it had increased. And then there were fewer longitudinal studies, so studies where we had data prior to the pandemic and could compare that with data during the pandemic. Overall, currently, the data is a bit mixed, with some finding increases in loneliness, while others show some degree of stability. These differences may be due to the differences in methodology, timing of the survey, and the sample that they included. However, many researchers, including myself, are still collecting data. Some of the most vulnerable and at-risk populations may be those that are most severely affected. So it's clear that there is health relevance of social connections or lack thereof, and that there is a significant portion of the population that is affected. And so important questions now are, what can we do about it? And this is an important challenge because, of course, there's currently no pill to solve this problem. And although pharmaceutical approaches are being explored in research, no one approach is likely to be the right solution for all, given the variability in underlying causes. Thus, tailored approaches are both needed and recommended by the National Academy of Science Expert Consensus Committee. And so while I wish I could offer you a quick fix, it's much more complex. But what I can offer you is a framework to consider. Solutions may benefit from a systems approach. And a systems approach recognizes that individuals are embedded within social structures such as families, neighborhoods, communities, society, and culture. And each level may contribute to health in different ways and may be interrelated. So it's important for us to consider each level in terms of both causal contributing factors as well as potential levels of intervention to modify risk and protection. So over the course of the pandemic, one of the comforting sentiments, at least when it comes to social isolation, has been this idea that we're all in the same boat, a sense of solidarity, that we're in this together, and the comfort in knowing that you aren't alone in this struggle. However, this analogy may be flawed. Perhaps a better analogy is that we're all facing the same storm, but we're in different boats. Some of us may be in a yacht, while others in rowboats, and some are going solo in a kayak. However, so we're not all equally equipped to weather this storm. And so this pandemic has highlighted a number of inequalities, many of which have become magnified in this crisis. And so this really is a critical opportunity for us to better understand these inequalities that, of course, existed prior to the pandemic, but how we may be able to reach those who may be most vulnerable. And so the electronic health record is an incredible resource to identify those who may be at greatest risk and to guide evidence-based decisions. For example, during the pandemic, analysis of nationwide database of electronic health records in the US, which included data from over 61 million patients, found that patients with a recent, meaning within a past year, so a recent diagnosis of mental disorder had a significantly higher risk for COVID-19 infection, hospitalization, and death compared to those without mental disorders. Similarly, another study published found a diagnosis of COVID-19 was associated with increased incidence of a first psychiatric diagnosis within the following 14 to 90 days. So given the strong bidirectional associations between social connection or isolation and mental health, it would have been ideal to have had social isolation and loneliness measurement included in the electronic record. to track who's most vulnerable and the long-term effects of the social restrictions associated with the pandemic. Of course, this need existed well before the pandemic and will continue long after the pandemic. In 2014, the Institute of Medicine identified social connection and isolation as one of the 10 domains most crucial to influencing health outcomes and treatment, and accordingly recommended that they be included in the electronic health record. And in 2020, the National Academy of Science Committee that I served on concurred with this recommendation. The evidence and need have only increased over time. Thus, it's imperative that we identify those who are most vulnerable to guide individual medical care and reduce risk, and to track long-term health consequences. And I certainly look forward to the efforts that the Gravity Project will contribute to this and to better understand and address this important issue. And happy to help in any way that I can. Thank you.
Dr. Holt-Lunstad, thank you so much. Yeah, I don't know if you could set the tone better than that for the work that's ahead of us over the next few months. Incredibly grateful for all of your assistance. Dr. Holt-Lunstad and Ed Garcia are available for questions briefly before they segue off to the rest of their lives on this April 1st. Does anyone have any questions? If so, you can either put them in the chat and I can forward them to them, or they can read them, or you can ask them unmiked.
Sarah, this is Lucy Johns. I can't find everyone for the chat, so I would like to socialize a question that I had to send privately to Dr. Holt-Lunstad. Please define loneliness. Is it like pain, a subjective state? If so, how is it defined for reporting purposes? Thank you.
Thank you so much for asking this question. And usually I have a slide with definitions in there, so I apologize for not including that. So loneliness is defined as a subjective feeling of distress, or a subjective feeling of social isolation that is often defined as the discrepancy between one's actual and desired level of social connection. So it is distinct from objective social isolation. Social isolation is objectively having few or infrequent social contact. So someone can feel lonely but not be isolated, and someone can be isolated and not feel lonely. But they do often go together, but not always.
Thank you. That's exactly what I was hoping you would say.
Any other questions for our amazing subject matter experts? Of course, they will be assisting us as we go forward in this work, again, with ensuring that the data sets we develop and build into a US terminology are aligned with the domains within their expertise. I'm incredibly grateful. I think everyone's taking it in. That was like, I feel like we just went to class in the best way ever. So thank you so much, Julianne. So Edward and Julianne, thank you again so much. We look forward to working with you over the course of time. I am gonna, you're welcome to stay as we plow through a multi-domain action-packed agenda. And then we look forward to seeing you on future meetings as we dive into more subtle concepts regarding social isolation and loneliness.
Thank you.
Yes, thank you, everyone.
All right, so briefly touching base on announcements. Again, my brain is just, it actually kind of made me kind of emotional, of course, because I'm a rural family practice provider. So this is my daily beat, taking care of individuals who, for many different reasons, have had a hard time for long before the pandemic, but even more so now. So next slide, please. This is our general sponsorship slide, just regarding seeking additional sponsors for our 2021 operations. Next slide. Always our invitation to attend the sister meeting that focuses specifically on the fire implementation guide on Wednesdays from 3 to 4, again available from the HL7 meeting calendar. Next slide. Once again, highlighting the opportunity for submitting letters of support to NCHS. There's 2 different pushes. One is due by April 9th, and this is a specific letter requesting the early release of the Gravity ICD-10-CM multi-domain submission. Usually when you present at the March meeting, the ICD-10 concepts should be released into the following calendar year's October release. So if you desire these concepts we've worked so hard on to be released into October 2021, we have a letter on the Gravity Project Confluence that you can reference, and you can reach out to NCHS directly if you so desire. Again, these are due by April 9th. And then there is the general full draft of the ICD-10 letter of support that you can find as well regarding the rationale for the submission as a whole. All of this information is available on the Confluence for your reference. Next slide, please. We do have a new Gravity Project website, soft launch. So it's initial landing page with some orienting information. Right now it's cascading to the Confluence. Eventually, yay, that was a cute little celebration. Eventually there'll be sub pages and then cascading to the Confluence, but we really are grateful for the collective. We had some secret shoppers again helping us make sure that it seems true to our principles and true to our mission and clear. So you're welcome to visit it at the link and give us feedback. As always, we are a collective, so we look forward to making sure it represents our work entirely. Next slide, please. Evelyn, are you still on the call?
Yes, I am. Sorry, I'll be just up in 1 minute.
Yeah, that's perfect. Okay, these next 2 slides are yours.
So just a reminder to everyone, if you have not seen this, ONC has published a new LEAP grant opportunity that incorporates the Gravity standards. So we're really excited to see the standards defined through this amazing collective being incorporated in policy and in grants. So here's an example. There are other standards, of course, called out, but it does specify the terminology standards and acknowledges the emerging fire IG standard. Applications are due May 10th. Next slide.
Evelyn, could I just interrupt to compliment you on your presentation at the ONC annual meeting that just concluded? And everyone on the call should know that Evelyn did a great job. And everyone on the call should rejoice that ONC is obviously taking social determinants of health way more seriously now than ever before.
Thank you, Lucy. You're so kind. And I appreciate, on behalf of my ONC colleagues, also appreciate the patience the participants had. We had some technical difficulties, but the panel team did great on pushing through. So we appreciate it. And thank you, Ellen. We can also share, those slides are available for those, and you could send me an email too. I think ONC had published how you can download the slides and the recording.
This work turns out to be so incredibly timely. Gravity was mentioned constantly during this conference, and Gravity is the only entity that's been working on standardized terminology so that EHR design can start to contribute to collection and understanding of data. It was really very gratifying.
Thank you. And I do see some ONC colleagues, so kudos to the ONC team for putting it together. And we, of course, within the Gravity Project are very grateful for their continued support. Great, thank you. I think there's actually 2 more, and the team knows I've been head to head today, but these are one grant came to our attention from our colleagues at NIH. They have these transformative grants have just recently been published to address health disparities and advance health equity at minority serving institutions. So we just wanted to make sure you're all aware again this opportunity for incorporating some of the work we're doing right now. I do not, and I've not gone in, I don't think these specifically require the use of the Gravity standards, but it is very relevant, and we want to make sure you're all aware. Next slide. Okay, back to you. I think we'll post, I'll ask Sarah if there was one more that recently published from the Administration of Community Living on No Wrong Door. I'll send Sarah that to post it. And thank you, everyone. Back to you, Sarah.
And have a good lecture, Evelyn. Evelyn's off to speak at a different session. So thank you, Evelyn, for joining us. Okay, so by top loading the social isolation kickoff in order to allow for our subject matter experts to come and go, we're now going to kind of go back in on the exit to our normal start. So next slide, please. This is just the orientation slide for the Gravity Roadmap. You can see we just kicked off social isolation. We're looking forward to kicking off intimate partner violence and elder abuse later on in April. We are midway through stress, and we are trying to wrap up concepts of material hardship. Again, we look forward to having a break really to work on dissemination and publication. We really have identified a need to assist our end users in understanding how this terminology and how our methods can be applied in clinical practice as they put these things into real use. And also we have some methods dissemination to publish regarding who we are and what we do and how it's unique. We get lots of questions regarding that. So we need to get those things into the public sphere. Of course, alongside the terminology work always is the technical work of the fire implementation guide and the reference implementation. Bob Dieterle and his team is working very hard on this. He'll present later on in the call. And then the work of the Gravity pilots. Next slide, please. Again, these are slides that we just referenced last time to kind of ground our work regarding the role of the community slide, the community collaborative. I'm just going to leave them there so if folks miss the live meeting and want to review the slides, they can do so later. One of the things actually I'm just going to highlight quickly before we go is, given that we are in crucial end-to-end review for material hardship, I want to remind all of our community members that the best and really almost the only way to really helpfully comment on the material hardship data set as we go through it today is to offer formal comment with rationale through email to the Gravity email, because that allows us to filter it through our subject matter experts, Dr. Jeffrey Colvin and Dr. Adam Shikadance, and the rest of our adjudication process. So that really helps us make sure that we assess these things correctly. Some of our members know that we have ongoing back and forth via email and via phone calls to resolve issues that have come up formally in the past. Next slide, please. And we also just want to mention that if a question comes up about a domain that was covered in a previous build, we'll try to drop information into the chat, and then we ask you to come back. We have conversations offline. A general concept is that given that we gathered subject matter experts by domain, and this will come up again today, if we touch upon concepts that cross domains we've yet to cover, we might pause on the build of these concepts and ensure that they're on our timeline. Again, referencing the timeline as grounded in the National Academy's paper about capturing social and psychological data in electronic health records that we referenced and grounded our work with at the last community meeting. Next slide, please. All right, any questions on the orientation? Okay, just trying to get everyone on the same speed. Next slide. All right, we have some material hardship stuff to work through. I did some homework. We all did some homework with our subject matter experts, and we have some stuff to present back. Next slide. Oh, here, the schedule first. Here we are at the April 1st. It's the social isolation kickoff. We're doing material hardship review regarding screening, diagnoses, goals, and interventions. So you'll see over the next day or so, I think Linda's maybe by Monday, you'll see the summary master set come onto the Confluence for your review. Again, it will contain the screening questions and answers that have been identified by public submission and the subject matter expert review and our curation of the literature. You'll see the diagnoses we've come up with, the goals we're suggesting, and interventions wrapped around critical material hardship diagnoses and concerns. We're also going through stress, just screening and diagnoses here, not interventions and goals. And then we're hoping to kick off the material hardship consensus vote the next time we come back on April 15th. Again, the vote will happen similarly to how we did it last time. So we'll have that voting period that will happen outside of the meeting in order to try to make sure that we can keep on going and not have everyone forced forced into the voting during the meeting per se. And then, oh, there's a little error in the slide here. And then, because it talks about material hardship happening again. And then on April 29th, we will be, I'm sorry, on April 15th, we'll be kicking off intimate partner violence and elder abuse. And then as we move forward into the end of April and through May, we'll be focusing just on stress, social isolation, intimate partner violence, and elder abuse as we finish out this quarter of work. Any questions regarding the schedule? Again, the only error here is that on the April 15th, it says we're reviewing material hardship and voting on material hardship at the same time, which we're not obviously doing. Next slide, please. Okay, so I'm just doing some orientation. So we're doing identify work. That was actually for social isolation. Next slide, please. Next slide. Okay, now reviewing the material hardship. Next slide. And next slide. So we're just reminding folks of the definition of material hardship. So material hardship as defined in the literature is the lack of specific socially perceived basic physical necessities. For those of us who've been on the call, we've been talking very intently regarding whether or not to define types of material hardship by the reason for the material hardship and how deeply to carry that into our terminology. You'll see some decisions and options on that as we go forward in our course today. Next slide, please. So when you look at the material hardship master that will be on the Confluence, you can see clearly that there are some additional questions and answers that are on the master list. Again, some questions are unattached to financial drivers. They just ask general questions of difficulty. And then even though some of them are suggested and some are very clearly attached to financial drivers, like trouble paying for things. So you'll see that as we implement these questions into our processes, they might map to some of the diagnoses that have drivers and others might not. And you can see this in the next slide here. So this is the slide that we spent a fair bit of time working on the last meeting, and there's been a bunch of updates. So at the last meeting, we presented specifically the unable to obtain and then X social necessity, and it was related to the financial hardship. There's a couple different reasons why it's changed right now. So as it stands right now, the way we are asking for it to be built is unable to obtain childcare due to limited financial resources. This was because the subject matter experts very clearly came back that a proposal of financial insecurity was not going to encapsulate the full breadth of the financial drivers for not having any of these elements, because financial insecurity as a domain, and we can remember this because we had it defined a little bit ago, is really a perception. If they didn't, a perception of financial stress or financial strain, and they didn't feel like this saying due to financial insecurity was accurate when aligned with the literature. And we, of course, we do not want to create unclear terms. So you can see the material hardship when it's linked to a financial cause is it's suggested the due to, which was the request of our colleagues in SNOMED, but it's due to limited financial resources. You can also see that we are suggesting those bare terms that do not have specification. We've gotten to a very long very long conversation on the last call regarding concepts of pre-coordination and post-coordination. And then we got a lot of questions afterwards about what we were talking about. So for the sake of the community, I'm just going to slow things down for a couple seconds and say, when we're talking about that, we're basically talking about linking two concepts in the code ahead of time or having methods within the interface to define cause after the fact, right? And we're happy to go more into that. There's pros and cons according to whether you leave things really bare, like unable to obtain childcare, or specify the cause, such as unable to obtain childcare due to limited financial resources. I am going to say the best way to align with the other domains as they've been defined prior is to actually attach the driver. Because if you think about concepts such as housing instability or food insecurity, most of them by definition are linked to financial drivers. You'll also see that as we get into some of the interventions, it's very difficult we're not ready to conceptualize interventions for non-financial drivers of material hardship. We just don't have the crew to do that. We were anticipating doing that work in the neighborhood and community level work in the fall. So right now we're hoping to kind of build a structure we can build on in the future by meeting the needs of our community members that want to keep it very simple with the unable to obtain childcare, unable to obtain phone, but then also allowing the direct mapping to those questions that ask about financial resources and can link to financial interventions. Any questions on this slide and what's happened since we last presented this to you all?
This is Tiffany. I have a question, and maybe it's something that's already been addressed, but when you were defining what material hardship is, I find it weird that childcare and dependent care is under material hardship because those don't seem like actual objects. So I was just hoping to get like some understanding on that, and maybe if that would help guide our wording on this about the financial security and if it would belong under that instead.
We have talked a fair bit about that concept over the course of time. And if we go back to the definition, I think the thought is that physical in this sense is not just the thing you hold in your hand, according to the subject matter experts. It's also the thing you can define and like name, like that, like resources, for example, are attached to physical as well. Like internet, for example, is difficult to define as physical in the same way. So according to the literature of material hardship, childcare has been a part of that. And then when we presented just childcare, one of our colleagues very elegantly said that we couldn't address childcare without addressing elder care as well. So it's very, I think. So what is the predicament? Because what is the predicament you're thinking about addressing? Because when we conceptualize community versus individual, community means it just doesn't exist. It's like the difference between broadband internet not existing in your community, like in rural Vermont, and not being able to afford the internet that's present, or like not being able to afford the childcare that is in your community, and childcare positions and options just not existing. Does that help?
Yeah, I mean, I think I was just thinking from a standpoint of you talking about how childcare and adult dependent care can kind of live under this area, and it also relates to financial hardship. I was thinking that this domain, I guess, is more material objects. So that was just kind of my thought process on that, but that makes sense. Thank you.
And again, I think I do want to honor the fact that the question you're raising is one that we've covered before. I think it was literally 4 or 6 weeks ago. So I want to honor the fact that that question is something that's come up, and it is a little bit difficult, but given that there's no other real place to define this concept right now, this is the area we're defining it within, and it does have pros and cons of doing so. Yes. And then, okay, so then Tom is saying, using the structure you're describing, would you use multiple codes? So I think, Tom, it depends on what you're trying to intervene on, right? What is the level of intervention? So as a clinician, I use as many codes as I need to address the needs of the patient in front of me. So I think if you're trying to intervene on, and again, I'm going to say very clearly here, part of the reason why we are, you'll see this actually, can we go forward to the intervention slide? I think this will be able to help. Just go forward one more. So one of the things that you're going to see right here is very clearly, and I said this in the kickoff, we are not in a position to actually have the team on hand to think about those non-individual level financial interventions, right? So really, honestly and truly, they would be both from a Healthy People 2020 perspective, from Academy's PEP perspective, really community level interventions, right? You don't solve broadband by doing something for the individual, you solve it on a community level. So even though we're building diagnostic space for the undefined material hardship, like just unable to obtain, because that was the request, or at least we are hypothetically building that, that's the proposal by the request of the community. The only things that we're able to clearly intervene on right now are those financial drivers, right? I don't have it because I can't afford it, because all of these have very clear programs that I can connect the individual to, whether it be through a community referral network, whether it be state or federal approaches. So that's the kind of the ground we're in right now. So Tom, I could answer your question and say very plainly, like, you assess and intervene, you assess as many things as you want to intervene on. So if you didn't have broadband and you couldn't afford broadband, you would assess both of them. But even a more simple answer is, I don't think we can answer that question yet, because we really need to save those community level interventions for our community work in the fall. Does that make sense? Because right now, the reason why we're talking about the undefined material hardships is because we're being asked to, right? But it opens up a can of worms from an interventions perspective that is not in the scope of this work. A can of worms in a gentle sense, like it's very important, but we really have defined that work is happening in the fall for community level stuff. And it sounds like that's helpful. So Tom, did that answer your question? Okay, it sounds like it did. Okay, and then Bill asked another very good question. Hi, Bill. It's nice to see you, talk to you virtually. So if we go back again, sorry, Linda, I'm making you work hard. So if we can go back to the diagnoses now, I felt like the best way to answer Tom's question was to show the slide. So we have the unable to obtain medicine due to limited financial resources question because there's very clear sets of questions regarding material hardship that were in our screening tools that were submitted that ask that specific question. In our research of SNOMED terms and our consideration, we had already planned, again, it sounds like I'm deferring, but I'm really just trying to create diagnostic clear domain space. We had already talked about addressing kind of more in-depth medical concepts regarding healthcare access and healthcare affordability, again, at later dates, because the truth is there are a lot of things we are not talking about here, right? So Bill, we're not talking about inability to afford to pay for copay. We're not talking about inability to afford your blood pressure cuff. We have not talked about them well yet, right? So if we desire them to be part of this work, even though healthcare access is kind of a whole other beast from a clinical perspective, we just need to make sure that we do that well in this period of time, right? So the good thing is there are SNOMED diagnoses already, SNOMED problem statements and findings already in SNOMED that address this. So should we want to elevate those concepts into our work, into these data sets, we can do so. Or we can ask ourselves whether cost and healthcare access are its own thing that we just kind of want to wrap around in a different way. Bill, does that make sense? And this is exactly what we need to be doing at this stage of the review. So I'm very, very grateful. So Bill, does that answer your question? Yes, good.
Sarah?
Hi, Lucy. Yeah.
Hi. For a consumer, from my point of view, medicine and medical supplies are the same, or they're so closely related, because if I can't get medical supplies that affect my health, that is, to me as a consumer patient, the same as I can't afford the medicine. So I guess I'm wondering, I appreciate that there's years of work behind existing codes about medicine and that we can debate for the rest of the day about access to anything in healthcare because of financial hardship. But I guess I'm back at square one now that Bill has raised this about medical supplies and whether we couldn't say unable to obtain medicine stroke medical supplies. Would that just be introducing such a can of worms that we can't do it? Or could we advance the conversation by thinking about doing that?
So Lucy, I think I agree with you that they actually are very similar. So the truth is that we just haven't talked about this well yet, right? So
Okay.
my first reaction, my first response when thinking about this ahead of time, and Linda could testify that we basically have been so focused on some of the other, social hardships that we haven't done a deep dive in here. And I don't even, again, think that that I think it might involve almost like a little task force, like Mike Klinkman is stating on the side. So it's not that they're different; they actually are the same. We just haven't done it well. We haven't kind of wrapped our brains regarding what are the things that we need to say regarding financial barriers to care. Again, I think we need to do that work. So my thought was to actually pause possibly on medicine and think about it separately, or just know that medicine's a placeholder for future work to come. But I fully recognize that experience, and that's the experience of the people and patients I care for as well. So we just need to figure out an action plan there, which might be medicine for now, comma, no, a whole bunch more work needs to happen. Does that make sense?
Great. As long as it's in the parking lot somewhere.
It's
Thanks.
seriously in the parking lot, and maybe I think it's urgently in the parking lot, and as echoed by some of our colleagues in the chat.
Thanks.
And Lucy and Sarah, this is Tom. One way to perhaps help think our way through that is to consider what are the available interventions to address those various types of medical need. For example, if it's a medicine issue, there are pharmacy subsidies for needing a device like a wheelchair. There's another set of options, and then say you need a ramp built to access your home or assistive devices within the home. Those are a completely different set of interventions through different agencies. So that might be one thing to keep in mind as we're framing how we develop the coding around these different types of needs.
Yeah. So Tom, you can see. So I believe you understand the subtlety here. So now I'm going to go back now again. I'm making Linda work. So let's settle on the interventions for a second, because I actually feel like that's really helpful. But I just want to make sure that, so Ellen, welcome, Ellen. So part of what we offer with that undefined is all of the other drivers without having to define all of the other drivers, right? So there is I don't have it because I don't have it yet because I'm on, a Section 8 housing thing forever, or childcare waitlist, a 3-year waitlist for childcare in my health service area sometimes. So that's part of not having it defined. And then Tom, yeah, so this mapping, right? So when I'm trying to really intentionally think about the continuity from the screening question and answer to the assessment of the concern, to the programs that one could intervene with, and how that terminology and the actual programs are all connected. And you can see in medicine, so we have prescription assistance programs and prescription voucher provision, right? And then those interventions are echoed all the way throughout the different drivers. So again, space for the fact that we haven't contained all of the different cost concerns with healthcare access at this time. We could build upon that work very similarly as we have here in time. So
Sarah, I just think we should keep in mind there was one wonderful slide during the ONC meeting. I think it was from the CDC. It showed inequity. Somebody on the call remind me, it started with inequity and it ended with risk factors. And the idea is that social determinants have such a broad potential influence. So if I can't get into my house because there's no ramp, and I'm in the nursing home because I've lost a leg and now I have to be in a wheelchair, I mean, that is so profound, and huge amounts of inequity result from that. So
we did actually
Okay.
include access as part of our inadequate housing work and referral. So one of the subtypes of inadequate housing was the ability to meet an individual's needs, right? To encompass those kinds of interventions. And then one of the program types that we built in was specific programs aimed at accessibility to try to address that concept. Hopefully. Lucy, does that seem to answer your thought there?
I guess I'm not sure, but let's move on.
This is building off of what Tom said, basically. So when it comes to barriers, he mentioned two different types, like medical supplies and accessibility for house. The housing one we covered inadequate housing. We haven't covered the supplies one or anything else beyond medications yet in this work, and we need to figure out where it belongs.
Okay.
Yeah, and I think so. This is the framing of the material hardship approach as it stands right now. I just want to go quickly back, and then we have to pass to Bob to try to. We do usually have an hour. Oh my gosh, we just spent a lot of time. Maybe we can go to our full hour and a half today. Just back one more slide. And again, if you have thoughts and comments regarding any of these, please send an email. Again, if you feel like this actually shouldn't be this way, we need your comment and the rationale, because there's a rationale for all the reasons why it is this way, all tracked. Like, we changed this because of this, we had to go this way because of that way. We've raised things that we don't have a rationale for, like why aren't medical supplies there? But most of the decision points we've come to have a rationale for why they're that way. So this is just a preliminary statement of two different ways to look at goal statements. So one of the complexities that we came up with regarding goal statements, if we just simply say has blank, like has heat and has electricity and has home cooling, our terms then conflate very closely with our inadequate housing terms, and it'd be difficult to differentiate, right? So I don't know, again, hypothetically speaking, whether we need to have very clear material hardship goals versus housing goals, but it might be, if we desire that, we need to enable like semantic understanding by stating this as different than that, right? So considering that with our subject matter experts, really trying to make sure that it wasn't able to be mushed into the house doesn't offer this, like my apartment doesn't have heat. We offer these two different concepts for you to consider with goals, and then we can go forward from there. And one might argue that the undefined material hardship is no different than inadequate housing. And so when you're not defining it, it doesn't really matter. But we do hear a desire from some of our community members to have goal statements that are about affordability. So this is why we offer these two versions, and we'll figure it out over the course of the next chunk of time, what's best. Whew. And then I'm going to try to pass the mic. Again, nothing much was changed during stress. Our subject matter experts are working very hard. This is really to get you all going. So we've presented a couple different things, material hardship. We presented on the inclusion of new screening questions and answers, the revision of our diagnoses statements in order to allow for the considerations of our subject matter experts. We talked about the absence of some of our medical concepts. And we talked about the rationale with interventions, which are aligned to our from everywhere from the screening questions and answers all the way to the interventions. And we talked about a predicament with goals that I'm hoping we can figure out over the course of the next couple of weeks. If we can go all the way to tech for Bob, we can just skip stress again because there's no new findings there. We're just gathering data. All right. Whew, Bob, I'm so sorry to take up all the time. Can you give us a few minutes of your time?
You did great. And thank you very much for responding to all of the questions you had. This was a great conversation. What I want to do is give a quick update on what we're doing on the technology side. Next slide, please. For those of you who have been on, you know that we validated an implementation guide in January. And we're in the process of ballot reconciliation. It's a guide that supports multiple domains. So it's a framework implementation guide covering areas, shall we say, clinical activity areas like assessments, health concerns, problems, goals, referrals, consent, and establishing cohorts for exchange of information. Next slide, please. This is the drawing we've been showing of the work that we've focused on, the interactions, the blue lines, the ability of a patient to be assessed. We're showing it inside of the provider's EHR. That's been noted a couple times that that's not the only place that happens. And in a little bit, we'll talk about what we're doing. Also, the ability to exchange information related to social determinants of health between a provider and a community-based referral organization or a community-based organization directly. There's slightly different process that we use for doing that, depending upon the technology that we assume is available. And then the idea of having potentially smartphone applications that can help people that have limited technology available to them, including the patient or the individual, to go and be part of that referral process or that intervention process. We also have focused on the ability to aggregate across individual patients based on common characteristics such as covered by the same payer, being referred to the same organization, et cetera, for the purpose of creating a cohort so we could exchange information related to social determinants of health when they have the right to go and receive that information. Next slide, please. You've seen this before. This is the stack we've been working with on intersection between the work that Sarah's doing and the work that we're doing on the implementation guide. And here we talk about the various, at least code systems that we're using, assessments and surveys, coded, health concerns, problems, and diagnoses, ICD-10-CM and SNOMED-CT, establishing goals, which are both LINC and now we're looking at SNOMED-CT, establishing interventions or referrals, again, SNOMED-CT, CPT, and HITFIX, and then measuring what was actually done as what are called prior procedures. Again, coded the same way, SNOMED-CT and CPT or HITFIX. And then ultimately using the procedures or the interventions that have been completed as ways of measuring outcomes and providing input into quality measures. On the right, we show the ability to deal with consent. We'll talk about that in a second on the next slide. And then on the left, the ability to aggregate data for reporting. Next slide, please. So what we did for a panel presentation for the ONC annual meeting, talking about data tagging and consent, is we focused on what we're doing for this first version of the implementation guide regarding consent. So we're assuming the ability of the individual and the provider to determine that consent is available from the individual to share information outside of a HIPAA-controlled environment. That's what we're focusing on right now. So to the extent that we're exchanging information outside of a HIPAA-controlled environment, then the consent remains with the provider, and the fact that we're allowing the exchange to take place infers that consent is available. We're not requiring the consent resource be exchanged with that, with the information, for example, to a community-based referral organization that does not have a business associate relationship with the provider. And you can see that on the right. In the event, or if we're exchanging it directly to a community-based organization that, again, does not have a business associate relationship. To the extent we're changing information from the provider to an organization that is a business associate, then we would exchange the consent resource to give the community-based referral organization the consent from the patient and the provider to go and further expose that information to a community-based organization. Next slide, please. One of the things that we have been challenged with recently is why are we limiting the implementation guide only to provider to community-based organization exchanges, rather than going and enabling the same exchanges for a payer, for example, or exchanges with government entities, public health, the ability for community-based referral organizations to exchange information with each other, and extending the idea that some of the community-based organizations may already have or will be interested in adopting FHIR capability. In other words, having FHIR-based APIs. So what we did was we took a quick look at the work we've done to date around profiles on these various FHIR resources, and basically realized that the work we have done applies to all of these exchanges. I think we had exactly one element that we had to go and change, and it probably shouldn't have been constrained the way it was anyway. So what we're doing is we're taking the implementation guide definition of how to exchange this type of information, referrals, interventions, procedures, conditions or health concerns and problems, outcome of surveys, and we're extending the workflow statements in the implementation guide to cover the various items that are here in blue. So basically all of the exchanges will have workflow definitions in the implementation guide. This is a complex slide. We go to the next one, which you'll see is we simplified it a little bit to basically say we're all connecting to the internet, and we have the ability to, or will be defining the ability to exchange from any of these organizations to another equivalent organization, meaning another FHIR-enabled organization. It doesn't have to be payer-to-payer or payer-to-provider. It could be a community-based referral organization to another one. Next slide, please.
Bob, there's a couple questions. I just want to make sure that you're seeing there's a couple questions of, I just want to make sure that we include them before they go away.
Oh, no, that's fine. Let's do that.
Yeah, so we have,
yeah,
so from, okay, so it starts with
Carrie?
No, with actually Dan C. Queries to identity, and then I sent Carrie a message. So it's Dan C, and then Janice Tuff. So first question is, shouldn't the SDOH access workflow include a query to identity? That's Dan C stating that.
Should the SDH access workflow include a query to identity?
And he also,
we're trying to establish patient matching here, I'm assuming is the question.
Yeah, I'm assuming he can probably unmute, and then he also asked about adding HIE as an actor. So I imagine this is going back to that previous slide.
That's correct. Can you hear me?
Yes, we can.
Yes.
Yes, we do identity management. We're assuming that identity is confirmed between the provider and the CBO.
That's correct.
It's a big assumption, right? And it's a risky assumption. So in an ideal world, we'd want some sort of confirmation of identity between the two actors. And then the third, or the other point that I was making, is that HIE solves the problem, right? Potentially, if HIE is in the middle, with identity, with consent, et cetera. And the OSC meeting, you know, Nebraska, Melanie's presentation made a strong case that SDOH should be, one of the purviews of health information exchange.
I'm certainly, there are a number of places where we have HIAs that we're working with that do support the collection and exchange of SDOH information. Certainly with Sync Health, with the work that's being done in DC and with CRISP. So there are organizations that are doing that already. We are not focused here on identity management. A large part of that's being done through the work that the multi-stakeholder work at ONC in a program called Fire at Scale Task Force,
yep,
where they're focusing on how you manage identities across various organizations. If you're familiar with that.
I am.
Okay, well, and I had the luxury of being one of the founders of that. And so we're assuming that a lot of the identity work is going to occur there and is occurring there, and we'll leverage that work. So what we're doing here is saying once we have established a couple things, establish the appropriate endpoints, establish the appropriate security or registration of applications, establish appropriate identity, now what are we going to exchange? What's the payload going to look like? So your points are incredibly important and well taken. It's just that work is being done elsewhere. Is that okay?
Yep, roger that. Thank you.
And we could, in fact, extend HIE to the concept of intermediary, which is really quite complicated, but of which HIEs are one example.
That was an excellent observation. Right now, I'm along with Alex Goss, I lead the FAST Tiger team focused on three things: directory work, which we've completed and moved to HL7, managing fire versions, which we have completed and ready to go and get subject matter experts to comment on. And we're doing work right now on intermediaries for exactly that reason. What do we do in the fire world when we have intermediaries? It could be clearinghouses, it could be just switches, it could be virtually anything, it could be an HIE. And what are the things that we're expecting those intermediaries to do with those transactions, including things like identity management, matching, conversion, consent. So yeah, this is exactly the place we're going, and these are excellent questions and observations.
And Bob, I wonder if,
I
I just want to make sure, so I'm wondering if we can consider some of these conversations, because some of the folks who are commenting are also in the technical advisory committee. So if there's further elements to discuss regarding both Dan's comment regarding query to identity and having HIEs be the actor, we can flesh that out there as well if needed.
Absolutely.
Okay.
I think that's a great idea.
That's a great idea, Sarah.
Okay, and I just for the program management powers that be, I believe Carrie's on the call, just so we don't lose that. I just want to add that to something that we need to consider in that group. And then there's enough common voices here that I'm looking forward to making sure that happens well. So thank you, folks.
All right,
okay.
Thank you. Next slide, please.
We do have one more, Rita, a different question. So we have Janice saying RX clinician prescribed many other supplies might not need to use RX, so perhaps, so we're the representation of the use of the word of the phrase RX. All complications of that are noted, Janice. I hear you there.
Yeah, that was for the last. I was responding to Carrie, kind of. Thank you.
Yeah. Oh, sorry. Sorry. I'm trying to do the, and then Rita's asking about eligibility status being a part of screening if someone doesn't qualify for material assistance and they still need and want it. I don't believe that element of this conversation's been addressed yet. Correct, Bob?
I don't believe it has either.
Yeah, we talked about.
We should be looking at.
Yeah.
Yeah.
Again, so one of the things that we might use this group for is, again, identifying things that we have to do a deep dive in, either in the technical advisory committee or in the specific HL7 meetings at 3 o'clock. And both of those things actually seem really important. So Bob, I think we've noted.
Absolutely, duly noted. Excellent observations. Thank you very much for the feedback. Okay, next slide, please, because I'd like to see if I can't get people out of here. Here's where we are in ballot reconciliation. As we said before, we wound up with 63 affirmatives, 30 negatives in the initial balloting. That met the 60% threshold that allows us to go on to publish the implementation guide once we have gone through ballot reconciliation. We had 227 comments, 72 are negative, 155 affirmative. If you have a negative comment, you're forced to vote negative, or the other way around. If you vote negative, you have to have a negative comment. So we're in the process of going through all of the comments. As of the 30th, we had 80 to go. The rest of them we have proposed dispositions. Our expectation is we'll finish ballot reconciliation by the end of April, which will meet our deadline here. And then with some of the additional workflows that we're adding, we expect to go and have those defined in time for the Connect-a-thon in May, the 17th through the 19th. And we're expanding the scope of the reference implementation to support those additional workflows. Should be done in time for the Connect-a-thon. And then we'll use the feedback from the Connect-a-thon and the work that we have done there to both update the reference implementation, update the implementation guide with the intent of publishing the guide by the end of June in time for our summer pilots. Next slide, please.
Bob, you canceled your meeting yesterday, if I recall. Are you on for the 7th? Could you just confirm?
Yes, we're on for the 7th. The only reason to cancel yesterday is that was when I was on the ONC annual meeting panel regarding data tagging and consent.
Okay.
So yes, we will continue to have the meetings. Just unfortunately, I don't control when they decide to have their panel discussions. Okay, let's see. We have another question here. Many states, if you focus on Medicaid. Okay.
Yes, Janice. Yeah, we do. We have considered that. One of the things we're working on ongoing within Gravity is an eligibility and enrollment panel for communicating cross eligibility status across different actors as well. This would be different than the screening questions and answer panels that we utilize, of course, for our domain work, but it's come up again and again and again as a need for sharing care across different settings.
Okay. So what's next? We're continuing to work with NLM and registries and other stakeholders to advance the tooling. We're also going and incorporating that into the reference implementation. Sarah is obviously working with the community, as evidenced by this call, to continue to establish the clinical content required for multiple domains. We are, as we said, advancing the development of the reference implementation. It's actually looking pretty good right now. We'll be able to go and have something fully implemented for the May Connect-a-thon. We're incorporating the dispositions from the ballot comments, and we're preparing for the May Connect-a-thon. We should have the track definition done by early next week, and we'll be sending out a general request for people to come and participate. We already have several people that have contacted me that are interested in being part of the Connect-a-thon and plan on bringing working systems or code to it. So it'll be a great opportunity to go and make sure that we're able to go and exercise the implementation guide before we publish it. The Wednesday call, Sarah already covered that. Please come join us. Sorry about it being canceled this week. We did do the cancel. If you're on the HL7 listserv, that should have been out to you on Monday. We had somebody on the call just in case you didn't get it and tried to join, letting you know that the call was canceled. Next slide, please. The reference implementation, this again is the same thing we've been talking about with the following exception. Down at the bottom, we are working on user interfaces for EMR, CBRO, CBO, and payer, and all of the exchanges that we have defined in those other slides. And we expect that for the new exchanges, we will have the ability to support them during the May Connect-a-thon. They may not be fully complete, given that we're starting them right now, but we'll be able to test the exchanges, even if some of the visuals aren't all there. I believe that's the end of it. Next slide, please. That is it. Do we have any more questions? No. All right. I think I'll turn this back over to you, Sarah, to wrap us up.
Yeah, wow. Okay, next slide. Thank you for bearing with us, folks. I did find some lit on while Bob was talking and I was running the chat. I found the foundational lit from ASPE regarding conceiving as childcare as a material hardship. So I will include that. I'll put that in the Confluence so we don't have to snag it and lose it. We have some material hardship concepts to review. I don't know if I actually see you. So we have to, we're hoping to aim for that vote again in 2 weeks. So if you have comments that need to be considered before we go to vote, please let us know via email, just gravity project@emiadvisors.net, or you can contact us through the Confluence. We are doing our stress and social isolation work going forward. As always, submit concepts over through the Gravity terminology submission process. We are so grateful for all of you. Thank you for spending an extra long time here on this April 1st, and I hope you all have a lovely day. Any final questions or comments before we end this call?
Thanks,
Thank you.
Sarah.
You're so welcome. We have an
Thank you,
action-packed
everyone.
agenda for the TAC next time. Promise to address those concerns, and we'll see you in 2 weeks.